Thanks, Dr. Goldenberg. So yeah, I'm Ryan. I'm one of the PGY2 urology residents here, and there's three main things that we'll try to touch on today. First, describing clinical characteristics of infection zones. Next, going into the pathogenesis of struvite and infection zones, and lastly, talking about management considerations. So first, starting off with clinical characteristics. Struvites and infection zones compose about 10 to 15% of the entire zone population. Of the Staghorn zones, struvite is the most common composition. Now, these Staghorn zones can form very rapidly, within the order of 4 to 6 weeks, compared to some other zone types which are a little bit slower. They're unilateral in most cases and about bilateral in 15%, and women tend to form these more commonly. With respect to the presentation, it's not the same as your typical renal colic, although sometimes can present as flank pain or vague abdominal pain in roughly 70%. Can present with fever in 25%, gross hematuria in 18%, and just under 10% can be asymptomatic. Other presentations in the literature include sepsis and recurrent urinary tract infections. In the natural course of infection zones, we know that they have rapid zone growth. There's a very high rate of recurrence in the order of 30 to 60, 70%. They carry a significant morbidity and mortality with them, and they often require aggressive treatment, whether it be surgical or through antibiotics. So some of the risk factors congruent with infection zones are similar to those with urinary tract infections in general. Females, people at extremes of ages, whether you're a premature infant or elderly, sometimes both. If you have abnormalities in the anatomy of the urinary tract, stasis from obstruction, urinary diversion, neurogenic bladder, or a diabetic. Now moving towards pathogenesis in infection zones, we'll first talk about the content. So as most of us are familiar with struvite, which is composed of magnesium, ammonium, and phosphate, this is a typical zone composition for an infection zone. However, it's not limited to struvite. Carbonate apatite is another key player, as well as monoammonium urate, and any combination of these or these in combination with other zone types. So underlying the formation of these zones is urease-producing bacteria. The most common urease-producing bacteria that we're familiar with in the literature is Proteus. Proteus, along with Providentia and M. morgani, are bacterial isolates that have been identified as producing urease 100% of the time. But there's also other bacteria that produce urease in a fraction.
Feedback. I'm sorry.
Yeah.
Jason? Jason? Some sort of a feedback here. You can fix it.
Tell us where the name Struvite comes from.
Sir von Struve.
Baron von Struve.
Looking at that guano. Okay, so of those bacteria that produce urease a fraction of the time includes Klebsiella. Of the Klebsiella bacterial isolates in one study, they found that 84% of these bugs produced urease, along with staph species in 55%, and E. coli, which is responsible for 34% of urinary tract infections, only produce urease 1.4% of the time. To put a little bit of perspective on the Providentia and Morgani, these were only responsible for urinary tract infections 0.2% of the time. So going to our how-to section of the talk, Martha joins us in discussing how we make struvite stones, and she'll have an issue coming out for the urologist soon. So we take our ingredients. We need urease, water, calcium, magnesium, and phosphate, and we put it together, and there's two equations, the top one for struvite and the bottom one for apatite. And what we need to know is that it's pH dependent. So going from the ions on the left to the end product on the right, if it's a basic solution and the pH is greater than 7.2 in Struvite stones, we're likely to get precipitation of Struvite. If the pH is less than that, it shifts the equation towards the ions. Similarly, with apatite, on the bottom equation, if the pH is greater than 6.8, you're more likely to get the precipitation of the apatite compared to if the pH is more acidic. So you put it together and crystallization occurs, and this can happen through two different methods described in literature. Intrabacterial, where you get crystallization within a bacteria, you get bacteriolysis, and you form a microlith, and then you get propagation of the crystal, and it forms a stone. In the extrabacterial crystallization, this is kind of more common with other stone formation, where you get a crystal forming and the bacteria actually gets incorporated with the stone itself. So the analogy that instantly came to mind from my childhood was the picture on the bottom, and this is the mosquito trapped in sap from a famous, well-known movie, and free coffee goes to anybody that can name it. Dr. Asher is good. So it's the same kind of idea with the extrabacterial crystallization. It forms, it incorporates the bacteria within the actual matrix of the stone. Put it all together, and you get your lovely Struvite Staghorn stone. Now, looking at these bacteria, there were some studies that compared the urine cultures with the stone cultures. Agashi in 2004 looked at the midstream urine cultures and found that it was positive 20% of the time. When they looked at the stone cultures, they found that the stone cultures were positive 50% of the time. So there's this disconcordance between the two. Similarly, in 2005, there's a study that compared these two cultures, and they only found a 23 to 25% congruence between the bacterial isolates from the urine and the stone. Interestingly, in the study, they also found that there's a correlation between size of the stone and the likelihood of getting a bacterial isolate, with the larger stone being more likely to grow bacteria. Now, Margol in 2006 took it a step farther, and we won't go into all the numbers, but essentially they looked at a midstream urine culture as an ability to predict if the stone culture was going to be positive. What they found was that it had a pretty low sensitivity, only about 30%, but the specificity was actually pretty high. It was 94%. So if the midstream urine culture was positive, you're pretty likely to have a positive stone culture. But if it's negative, then it doesn't necessarily mean that the stone culture is going to be negative. Now, if we remember back to talking about how the stone composition could be a combination of several different components, Bulk in 1990 looked at stone composition with respect to Struvite. So what they found is that in stones that have greater than 80% Struvite or apatite composition, these always cultured urease positive bacteria. Now when you bring it down to 20 to 80%, it's still largely urease producing bacteria that's cultured, but once you get below 20% Struvite or apatite composition, then it's growing largely E. coli, which you recall only produces urease 1.3% of the time. So why are these stones so bad? They harbor infection within the actual matrix itself. They harbor infection on the matrix of the stone. They develop these biofilms from exopolysaccharides that actually make the antibiotics very difficult to work. It's been quoted in the literature that the presence of a biofilm requires 100 up to 1,000 times the MIC to actually cause bactericidal effects. So the dose of antibiotics that we're using typically won't kill these bacteria. Additionally, you get inflammation, which increases mucose secretion, and this serves as a matrix for further crystal aggregation and stone formation. Finally, the ammonia, it damages the glycosaminoglycan layer, which increases the bacterial adherence and transition into the actual urothelium, putting you at risk for infection. Now, shifting gears a little bit to management considerations in struvite stones, if we think back to Tetris, we see that this T-piece clearly is not going to come down and go through the ureter here. It's just not going to fit. In the absence of having your local magician Samir and making it just go away, we have to consider other options. Now, some important studies that have brought this concept into the literature is Dr. Teichmann and his group in 1995 in a subset analysis of patients that were presenting with Staghorn stones. What they found is, of those that received treatment and had complete stone clearance, none of these patients had mortality related to renal failure. Of those patients that had treatment of some form but didn't have complete stone clearance, there was one death, and that was related to renal failure. Now, there's 3 patients in this group, and it's hard to say exactly what their baseline health status was, but 3 patients that didn't agree to any treatment whatsoever. In this series of 7.7 years of follow-up, all 3 of these patients passed away, and 2 of them were related to renal failure. Similarly, in 1990, Koga and colleagues looked at conservative therapy compared to surgical intervention. Now, these patients were accrued between 1965 and 1984, so it's a little bit limited, and they didn't define exactly what conservative management was, except the fact that there's no surgical intervention. So here they also found a higher incidence of chronic renal failure in the patients that weren't surgically operated on. The most common reasons for this renal failure was bilateral Staghorn stones, calculi in the contralateral kidney, and in a few cases for both the surgical and conservative management, chronic pyelonephritis was attributable to the renal failure. So what we've learned is that conservative therapy likely carries increased morbidity and mortality and increased rate of chronic renal failure. So there's 2 goals of therapy. One is complete stone clearance, and second is eradication of the infection. Looking at our different options to treat this: antibiotics, urease inhibitors, dissolution therapy, acidification therapy, shockwave, ureteroscopy, PCNLs, and anatrophic nephrolithotomies. So first, talking about antibiotics. In the guidelines, there's guidelines regarding stones in the CUA, AUA, and EUA. Within the CUA guidelines, it speaks largely to metabolic workup, but there's little about infection stones. In the AUA guidelines, there's a significant section on infection stones, and they recommend that antibiotics be used, and likely in a long duration, but there's no specific recommendation or logic process to differentiate who should get what duration. Similarly, in the EUA, they recommend that either short-term or long-term antibiotic therapy be present in stones or patients with struvite stones. So if we look at some of the experience in the literature, Stream and their colleagues in '97, they reported that they used 1 to 2 weeks of oral antibiotics pre-procedure, and that were specific to the midstream urine culture that they had had previously. 1 to 2 days before the procedure, they would introduce broad-spectrum IV antibiotics, and they would perform the procedure. What they found was that even in the presence of this prophylaxis, they still had a 33% fever sepsis rate amongst struvite stones. This was higher than non-struvite stones, which were about 12%. So if we look at post-operative antibiotic trends, the same group proceeded to give the IV antibiotics 24 to 48 hours following the procedure, and then 1 to 2 years of low-dose suppression antibiotics. Another group, Dissolution in 2000, reported giving low-dose suppression antibiotics for 3 to 6 months following procedures. Locally here, the common practice, as I understand it, is that we give suppression antibiotics for upwards of 3 months. This brings us to the point where we get repeat imaging following a procedure at about 3 months' time with the CT-KUB. And at that point in time, we can decide if the antibiotics should be continued and their stone fragments, or if the person's stone free and we can follow them. So putting it together, we see that Staghorn stones require antibiotics preoperatively and around the time of surgery or procedures, as well as if they have fragments, and in some cases if they're stone free for a period of time. Moving on to shockwave lithotripsy. There was a study in '97 that looked at shockwave as a monotherapy in Staghorn stones. Of the 60 stones, most of them were partial Staghorns, but there were 11 complete Staghorns, and they had a stone-free rate of 28% at discharge. And as you can imagine, given the mechanism of shockwave therapy, at follow-up in 72 months, I don't think it was the first follow-up, but at 72 months, they had a stone-free rate of 60%. An additional study in 2006 looked at 92 partial Staghorn stones, and they had slightly better success with a stone-free rate of about 60%. Amongst these patients, they had complications in 13%. 10 were related to obstruction, and 2 were related to fever and sepsis. Of these patients, there's several ancillary procedures that were required for ureteroscopy, stent placement, percutaneous nephrostomy tubes. Shifting to the pediatric population, there was a study in '99 that had a pretty small subject group, only 15 patients, but these range from 14 months of age to 11 years of age, and they looked at Staghorn stones and shockwave therapy. They had fairly good success with a stone-free rate of 73% over the course of an average of about 2 sessions. Now, some of the complications listed in the literature include renal colic requiring readmission, hematoma formation, pyelonephritis, sepsis, Steinstrasse, ureteral obstruction, and potentially loss of the kidney. In the AUA meta-analysis that was performed in 2005, they quote an overall complication rate of about 20 to 50%. So if we look at our flow diagram, patients that are not likely a great surgical candidate, or in the pediatric population, shockwave therapy could be considered with the addition of antibiotics and some adjunctive therapies that we're going to touch on here. The first one that we're going to talk about is Urease Inhibitors. In '91, there was actually a prospective double-blind placebo-controlled trial looking at acetohydroxyamic acid versus a placebo. They accrued 94 patients that had chronic urinary tract infections, and their primary endpoint was stone growth. So did the stone grow or did it not grow? What they found was that in the treatment group, only 17% of patients had stone growth, compared to 46% in the placebo group. 22% of this study population had side effects, and they're typically dermatological, hematological, or neurological in effect. Next is dissolution therapy, and it was first described in 1932. By 1938, Hellstrom used boric acid and permanganate. I suspect it was probably a resident that they first tried it on, but I'm just speculating. Suby and colleagues in 1943 described Suby G solution, and this consisted of citric acid, magnesium oxide, and sodium carbonate. Then in 1959, Mulvaney described hemosiderin, and this is really similar to Suby G solution, except they added D-gluconic acid. Now, the experience within the literature here was that there were several patients that became quite septic, and there's a few deaths that were attributable to these formulations. The FDA took it off the market in 1962, and then with more stringent contraindications, it was reintroduced to the market, and there was actually a study done in 1999 that looked at shockwave therapy and ranitidine. So of the 118 patients here, they had a reasonable stone-free rate of 60%, but the greatest downside was that the average hospital stay was 32 days, which isn't really a great option from a resource management perspective in Canada, as this would be extremely expensive. The other point that was made was that the solutions couldn't be used in the presence of an active urinary tract infection. Of the complications, there were 2 septic patients that required IV antibiotics. 1 patient went to the ICU, and there were 15 patients that needed nephrostomy tube to be realigned. We're just going to briefly touch on acidification therapy. It hasn't been used greatly within the literature more recently, but there have been several different agents that have been considered: ascorbic acid, ammonium chloride, sulfate, nitrate, and L-methionine. The general trend with these different therapies is that if it's in the presence of a bacterial infection, they're not particularly useful. However, if you use concomitant antibiotics, you do get a decrease in pH, and for a certain period of time, it's held. A main criticism within each of these is that within time, the pH often increases back to where it was prior to treatment. Looking at ureteroscopy as an adjunct, there were 2 studies that I just mentioned. Both have pretty small sample sizes, but Margaret in 2005 looked at ureteroscopy prior to PCNL with the hopes of decreasing the number of puncture sites and decreasing the blood loss. So this was performed, ureteroscopy with an access sheath. Then PCNL was performed on the patient, and they had a stone-free rate of about 71%. The mean operative time was pretty comparable, and the blood loss was actually lower in the ureteroscopy group with an average of 79 milliliters compared to 345. In 2003, Landman and their colleagues had 2 surgeons working at the same time, one performing ureteroscopy simultaneously as a PCNL was being carried out. The stone-free rate here was comparable at 78%. However, there were a significant number of minor complications that they noted. Putting these together, the role of ureteroscopy is probably not necessarily what these 2 studies described, but more in keeping with treating stone fragments that have dropped into the ureter, or if there's a low stone burden in the actual kidney itself. The urease inhibitors and dissolution therapy could be considered to be used in combination with shockwave therapy in patients that aren't great surgical candidates. Looking at our gold standard, PCNL, in '97 there was a study that compared the shockwave lithotripsy that we just spoke about with PCNL. In their group of about 50, they found that the stone-free rates were 74% in the PCNL group compared to 22% in the shockwave group. However, they did have significantly more complications in the shockwave group, with several of them requiring additional procedures. 7 patients needed nephrostomy tubes for obstruction. A PCNL had to be carried out in one of the shockwave patients for large stone burden, and ureteroscopy for Seinstrasse on several occasions. In 2005, PCNL was then compared to open surgery that we're going to move to shortly, and they found that in their study of 88 patients, stone-free rates at discharge were 49% in the PCNL group compared to 66% in the open group. At 3 months' time, the same relationship existed between the 2 types of therapy, but they did note several benefits of the PCNL. One was a shorter OR time, 127 minutes compared to 204 minutes, less intraoperative complications, 16% versus 38%, lower transfusion rate, 14% versus 33%, and a shorter hospital stay of 6 days compared to 10 days. Now, this isn't exactly representative of how our institution does PCNLs, as we typically have people out within 1 to 2 days postoperatively. The last one on PCNL is Wong in 2001, and this brings us to practice at VGH now. They introduced the addition of flexible antegrade nephroscopy through the percutaneous site. They had very good experience with the stone-free rate of about 95%, and they had a shorter hospital stay of approximately 2 days. On average, it took 1.6 procedures to complete clearance of the stone, and the estimated blood loss on average was lower than previously stated of 238 milliliters. The complication that they endured in these patients was an episode of hydrothorax, and 6 patients had febrile episodes. Complications noted in the literature include blood transfusion with a rate of 2 to 18%, incomplete removal between 5 and 21%, fevers in 11.5%, hydrothorax is possible with the supracostal access site, colon injury, perforation, DVT, prolonged leak, and vascular injuries are possible. Looking at long-term potential complications, you can get decreased renal function, recurrent stones, stricturing, perinephric collections, and AV fistular pseudoaneurysm. Putting it into our flow chart, PCNL is the gold standard, and this is typically what is used for treatment of the Staghorn stones. And if they're a surgical candidate, this should be strongly considered. Our last section, speaking to anatrophic nephrolithotomy, there was a study in '98 that had 14 patients performing open anatrophic nephrolithotomy. Some spyware on here. So in this group, the average OR time was just over 200 minutes, and the blood loss on average was about 750 milliliters. These patients stayed in hospital for just under 6 days, but they had a very successful stone-free rate of 93%. Comparing this to laparoscopic that was introduced a little bit later, in this group with Geidelman and colleagues in 2012, they had a smaller study sample of 8, but their OR time was significantly reduced, less blood loss, and a shorter hospital stay. However, their stone-free rate was only 63% in comparison. Some of the potential complications with these procedures include losing the kidney, if you have a persistent sinus tract, persistent urine leak, ureteral obstruction, vascular injury, and there was a couple of reports of pulmonary embolus in the literature. So anatrophic nephrolithotomy is likely reserved for patients that have failed PCNL and it hasn't been successful. If they have anatomic abnormalities like infundibular stenosis, although there's potential ways within PCNL to get around that, or in morbid obesity, the literature has commented that this might be a viable option. Here's a nice summary chart that I took from the AUA guidelines, and it was just comparing the stone-free rates amongst all of these different types of therapies and the 95% confidence intervals. As you can see at the top, PCNLs have a very good stone clearance rate and less deviation than some of the other procedures. Move on to a unique circumstance. This patient developed a pelvic Staghorn stone in a pelvic ectopic kidney. Anybody in the audience come across this or have comments on how to treat this? Dr. Patterson? Great. So he said lap-assisted PCNL.
But you've got to look at the films first, because sometimes there is a window that someone like Alan could give you. But I would say that in the majority of circumstances, due to the malrotation of the kidney, the patient is not consistent. That's what's important.
The other thing is that in ectopic kidneys there is a higher percentage of congenital anomalies such as UPJ.
Mm-hmm.
Remember from previous. So that also could affect what you're going to do.
Okay.
Why not just do it with fellow body?
Pardon me?
Why would you just do it with
You can. That's another alternative, but the morbidity of the lap-assisted electro is quite
So that was done. What was done in this case as well was a lap-assisted PCNL. So what they did was they placed a lap camera site, then they introduced an instrument site, mobilized the bowel until the kidney was visualized, and then with ultrasound and fluoroscopy, percutaneous access was gained into the kidney and a PCNL was carried out. There's been a few case reports and a few case series going through management of these, and all have had fairly good success rates. Just like to thank Dr. Chu, Dr. Teichman, and Dr. Lynch. Thanks.